Well, hello, everyone. Welcome to our lecture today. I am Cindy Rubin. I am a breastfeeding medicine doc and pediatrician. This is a little bit about me. I am in the suburbs of Chicago, the western suburbs of Chicago, and I have a tiny little micro practice, home visits, where I do general pediatrics and breastfeeding medicine, as well as fourth trimester care packages. And I wanted to talk to you guys today a little bit about breastfeeding medicine and lactation and how you can help your patients when they are in front of you in the office, because we do not get enough training on this in medical school and residency, and we see a lot of it, especially if you're a primary care physician. So hopefully this will help you have some tools in your pocket of how you can help your own patients. So I wanted to start by just talking a little bit about breastfeeding medicine itself and what it is, because this is not really new, but it's new to many people, and sometimes people aren't quite sure how this differs from lactation consultants and what exactly we are trying to get at with breastfeeding and lactation medicine. And what it is physician level care by doctors who have received physician level training in breastfeeding and lactation. So we can help to troubleshoot, evaluate, and manage more complicated breastfeeding problems that may come up with your patients. IBCLCs can do education and counseling, but kind of get stuck when there's something that actually requires labs to be done, imaging, a diagnosis to be made, and some sort of treatment management plan to be come up with. And unfortunately, the other people on the front lines, the physicians, don't always know what to do. So there are breastfeeding medicine docs out there who can help with those things. And we're working on a certification program for breastfeeding medicine as well, which hopefully will have its first set of docs sitting for the exam sometime in 2024. So something to look forward to. So let's get right to it. I have a lot of information in here, and feel free to throw some questions at me if I go too quickly through anything. So we're going to talk about just some common problems that you might see in your office and how to handle them, at least how to start the management. And I wanted to talk first about latching, because latching is probably at the heart of what we need to get right in those first few days and weeks in order to have a smooth journey with lactation. And I wanted to just go over what a deep latch looks like, what a good deep latch looks like, so that you can better evaluate this with your own patients in the office. So as you can see, we've got a baby here, and you can see how wide open this mouth is. So we want to have a very wide open mouth, an off-center latch, actually, and we're going to talk a little bit more about this. And in the end, with this off-center latch, you're going to see that the lower jaw takes in more of the breast than the upper jaw, or, up here by the nose. So that's what we mean when we say off-center. What that does is it gets the nipple in the right place in the baby's mouth, so that the baby can be more effective and it's going to be more comfortable for the mother. And that aim is for that nipple to end up right at the junction of the hard palate and the soft palate. And then finally, this is going to lead to better milk emptying and, again, better comfort for the mother. Oops. So I love showing my moms this, and we can have the links for you guys for some of these resources. This is from Nancy Moorbacher's website, and it is a really good way to just show what you're talking about if you say all those things that I just said, so that your patient can have a visual of what things are going to look like when they put their baby to the breast to achieve that off-center, comfortable, effective latch. So when you have your baby in a position so that the upper lip or the nose are kind of at the level of the nipple, as you can kind of see here, then the chin actually is the first part of the baby that typically is going to touch the breast over here. And that's going to put the lower lip about at the edge of the areola. Now, this is all give or take. Everybody's areola is a different size, so this isn't always going to be exact science. But in general, you're going to be down here, so that from a vantage point where a baby is kind of looking up towards the nipple or up towards, basically looking up. And when that chin hits the breast, it really triggers that mouth to open nice and wide and for the baby's neck to extend. And that is the point at which you want to kind of guide the baby then over the nipple onto the breast, and without necessarily like completely taking that breast and sticking it right in the mouth, because when we do put the breast and then the nipple straight in a baby's mouth, we tend to end up with a more shallow latch, which is more uncomfortable and more difficult for the baby to express the milk. So this is perfect, and this, perfect looking latch here, which is never is quite as easy as it looks on paper. So though I'm saying this in a simple way, it's not always this smooth, and it does take practice. And I think reassuring moms as you're going through this process that it's a learning experience for the mother and for the baby to kind of get the fit that works best for them. And this is, again, a general rule that this is what is going to work for most people, but not everyone. So when you see this baby, I will usually watch to see how a mom is already latching their baby, to see if there's anything that needs tweaking. And when you're kind of lining up your baby, we're not going to go over positions, all the different positions today, just no matter what position you're using, this is kind of where you want the baby to be positioned and how you want them to come at the breast. So in this picture, you can see that baby's kind of got their head looking, they're looking upwards, their neck is extended, and just literally scooching a baby all the way so that their body is further away than you think it needs to be, or more laterally or medially to the breast than they probably are, depending on which side your baby's on related to the breast. That will often help to get baby in that position. So if you scooch the baby so that they will have to look up to look at the breast, that's a good way of thinking about it to get them in the right position. So here you can see how the chin hits the breast first, and we're all the way down here. The chin is right around where the edge of the areola is. And then the baby opens their mouth nice and wide. And ideally, then baby can just come forward and get their upper lip over that nipple. But sometimes the baby's mouth is small, sometimes the nipple is large. So sometimes you have to do a little bit of finagling here. This mother also is kind of pressing with her opposite arm to pressing into the breast, and that's aiming that nipple up towards the baby's nose, which also helps to get things in the right position. And baby comes forward, puts their mouth over the nipple, and there we are with this beautiful latch, which maybe you could have the mouth a little bit wider. It's just my first look at this particular picture. But this is a really good way of seeing step by step generally what you want to see happen. I do have a little video here. I'm going to come back to this and I can give you guys the links. But because we have limited time, I'm not going to show you that right now. But what I do want you to see is this beautiful video of a baby actually eating at the breast, because first you want to evaluate the latch itself. But then you want to be able to watch a baby eat, which I think is very important if you have the time to do it, and be able to know yourself and also teach the parent how to evaluate whether their baby is eating well. And so a baby who's eating well, you want to look at their position, again, the latch, we already talked about that, and then how efficiently do they seem to be eating? And you'll see in this video that this is a really nice suck swallow ratio. So ideally a baby should be swallowing every 1 to 2 sucks once the milk lets down. So initially babies are going to suck kind of quickly and not too much swallowing until that milk lets down and starts flowing. And you can usually see a change in the pattern, which I don't have here, unfortunately. But this is just going to show you once the milk lets down. And then babies take natural breaks too while they're eating. But those breaks should be after a little bit of eating. So babies should be doing a few of those suck swallow bursts before taking a break. So 5 to 6 is ideal, but at least 3, 4, 5 swallows before taking a break. Some babies will take a break after every single swallow. So they'll suck, 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 swallow, break, suck, swallow, break. And that they may be able to eventually have a whole feeding that way, but it's going to take a long time. And it shows that something's not quite right, whether it's a sleepy baby or the mechanics in the mouth, they're having difficulty drawing the milk out, or potentially we have a milk production issue. So I want to show you what this looks like when a baby is eating well. And hopefully you can hear the swallows. Oops. Yeah. And the swallows are going to sound like g, g, g. So you can see this baby is swallowing every 2 sucks. And here baby pauses, comes back from that pause all by himself. Making cute little baby noises. And you can see how his jaw kind of comes down a little bit further. And he has a little bit of a different jaw excursion on those when he is swallowing. So you can see that also when you can't hear it. And baby's in a nice position here. His tummy is right up against mom's tummy. He doesn't have to turn his head at all to be able to nurse, which is very comfortable. And he looks nice and relaxed. So this is what we want to see. And we've got Big Sister in the background playing, which is all right. So now that you know how to evaluate a baby, what if mom actually comes in, or parents come in, and there's actually encountering a problem, and you want to know whether it's something that you can handle or where you need to send them. And even if you need to send them somewhere else, it's nice to know how to initiate a little bit of treatment or give parents some recommendations in the meantime. Okay. So breast and nipple pain is a very, very common problem. And this is something that is not infrequent, especially in the very beginning as babies and moms are getting used to things and the latch may not quite be right yet. But breast or nipple pain that is truly extreme pain, like toe curling pain, and is really interfering with their relationship and not getting better after a few days, is something that needs to be evaluated. So I have a large list here of possible causes, and we're going to go over just a few. The main thing that I want people to know about, well, first of all, always go back to this latch at the top. Okay, so number one, if there is pain, watch that baby latch, watch that baby eat, and see if you're seeing any big red flags right off the bat, and see if you can maybe move things just a little bit, tweak things a little bit to get things more comfortable. But if not, then a big main point that I want to make is that it is almost certainly not yeast. And this is something that we learn in one of the few things that we actually do learn, I think, in med school and residency, and it's actually incorrect, which is that almost all of the pain that moms come in with, if it's not attributed to latch, ends up being attributed oftentimes to yeast. So people are told that they have breast yeast or breast thrush. And in fact, introductal yeast infections are exceedingly rare. And even skin infections, though possible, skin infections around the nipple are much more likely to be more of a contact dermatitis or bacterial than yeast, unless you do see yeast, evidence of yeast overgrowth in the baby's mouth or on the baby's bum, or, there's some known exposure to yeast infection. Though if you think about yeast and why yeast infections happen, they happen usually because of immunosuppression, or there's some amount of immunosuppression going on, or something that is making that host more susceptible to yeast overgrowth. Though we all have yeast living on our skin. So it's not just the presence of it, but it's the overgrowth. So even in a baby who has overgrowth, because this baby's immune system is very young, there may not be yeast it's not necessarily contagious to the mother. So mothers do not automatically need to be treated for yeast infections if their baby has a thrush, but the mom has no symptoms. And, something that I used to see, I was hearing that it's not yeast, but I thought, but it's interesting because most of these mothers who get treated with oral antifungals for presumed yeast infections do seem to get better, but then they get worse again and they get treated again. And it's kind of just repeat treatments until they finally either they give up or they find somebody who can kind of evaluate them and manage them more thoroughly. That fluconazole, which is the typical oral antifungal that we'll use for breast thrush, or for presumed breast thrush, has anti-inflammatory qualities to it, and it also has some antibacterial qualities to it. And it is actually probably those things, especially the anti-inflammatory qualities, that are helping the symptoms. And that's why it gets better while they're on the medicine, and then it comes back pretty quickly afterwards. And eventually, usually doesn't hurt, because eventually there's just so much inflammation that it's not going to help. So what is it when these moms come in? So I'm just going to very briefly comment on two very common causes, and maybe we can do another lecture sometime, or one of my colleagues can do another lecture sometime on more specifically on pain. But vasospasm is actually a more common thing that we see as a cause. And vasospasm, it's similar to Raynaud's, though Raynaud's is an autoimmune situation. It's similar in the sense that we have this distal ischemia, color changes, and pain from lack of good blood flow circulation to those distal tissues. This is often the diagnosis when women come in complaining of burning, sharp, stabbing pain, usually specifically more centered on the nipple, but it may sometimes, when it's extreme, they may feel it in more radiating to more of their breast. It's due to ischemic changes. So we'll see this when there's a poor latch, or in exclusive pumpers, if there's something that is not quite right with the pump setup, or even if the pump setup is as good as you can get it, just exclusive chronic pumping, it's not natural. And so as that nipple is being pulled into the flange, and then some areola is being pulled in the flange, there is compression of those tissues, which leads to ischemia of the tissues, which leads to the vasospasm, which is the vasospasm, and leads to the pain and discoloration. So we can see anything from white to blue to purple to red. It's very similar to with Raynaud's phenomenon. And you can see in this picture, we've got this purplish blue hue to the surface of the nipple. And it's a little hard to see here, but you can kind of see a band of that as well at the base of the nipple. And this was an exclusive pumper with very extreme pain after using high suction and, also a lot of different things that could have led to this. So the warmth, similar to Raynaud's, the treatment, similar to Raynaud's, is with warmth. And you want to fix that trigger or minimize, try to tweak the trigger so that it is not able to cause as much trauma. And then there are some medications, calcium channel blockers are the mainstay. But interestingly, Zoloft can help as well. SSRIs can help as well. So, but if you have an extreme vasospasm and warmth is not helping, you think that that's what's going on, but warmth is not helping, then that could be time to seek out a breastfeeding medicine physician to get some more help. Mammary dysbiosis is another cause, and this feels a little bit different to moms. Mammary dysbiosis, similar to gut dysbiosis, is when we've got, for some reason, bacterial overgrowth, an imbalance in the typical bacterial growth in the breast. And this can lead to inflammation, biofilm formation, various different things that can lead to this chronic level of inflammation, and which leads to then tenderness of the breast, and can also make moms more prone to getting plugged ducts and mastitis. And we're going to talk a little bit more about that as we move on. But this is often described more as a deep breast tenderness, and there'll actually be tenderness on palpation of the breast. It can be somewhat localized, but it's often fairly diffuse. And the treatment for this, if you think it's going on, first off, this may need to be treated with antibiotics. So if you think that you're going to need to be treating with antibiotics, getting a milk culture can be very, very useful, not to diagnose mammary dysbiosis, but to guide your treatment, because you can get the sensitivities of the bugs that are there so that you can be sure to put this person on correct antibiotics. And there's some specific guidance on how to do a milk culture and how to send the milk culture to the lab and what to tell them to do. Because interestingly, staph epi or coag negative staph is a common culprit in mammary dysbiosis when there's overgrowth. And depending on how you send the culture, it may not even be identified, because you may get a result that just says that there is normal flora. But if you send this as a body fluid culture, a sterile culture, not a wound culture, then they should identify something like coag negative staph. And then you need to ask them specifically to do the sensitivities on coag negative staph if they find it. But going back to treatment, that's kind of the next thing potentially, but just like with vasospasm and latch, you want to manage that trigger. So whatever you think might be causing it. And this is very common in exclusive pumpers. So if you have somebody who's exclusively pumping and they seem to be developing this sort of pain, trying to decrease the amount of pumping that they're doing and move towards more direct nursing can be very helpful, or watching how they're pumping and optimizing flange size and strength of the suction and all sorts of other things to make it as close to physiologic as we can. And probiotics, there is not great evidence yet to support the use of probiotics, but first of all, as we all know, probiotics really can't hurt. And I have found in my own clinic with my patients that I rarely actually have to go on to give antibiotics if I start probiotics and work on whatever that trigger may be. The other triggers, of course, are taking antibiotics or antifungals, which by the time they get to me, oftentimes moms have been treated with multiple courses of all of these things because of presumed mastitis and thrush and all of those things. So this is actually quite common. And sometimes just managing the trigger and probiotics, there's specific probiotics that you want to use, which are L. fermentum and L. salivarius in particular. So you want to look for those. It's not the typical ones that we use in the gut for the gut necessarily. But if you do end up needing to treat with antibiotics, then it's typically a longer course of antibiotics. So 4 to even sometimes 8 or more weeks of treatment until the patient is asymptomatic. So no pain, not getting any more plugged ducts, mastitis, or other symptoms that they may have had. And again, this is why we want to get that milk culture first, because we are putting this person on long-term, prolonged antibiotics, and we want to make sure we're using the right one. Okay, so we could talk way more about each of those topics, but I just really wanted people to know that those exist and to know that those are more common than yeast, and that there are people out there who can help you with treatment if you think that your patient has one of those. So our next problem is infant refusal to latch. So this is not uncommon for a variety of reasons, which I'm not going to go into all of those things, but here are a few things that may lead to this. But sometimes what happens is there's an underlying reason why that baby is not wanting to latch or is having some negative reaction at the breast. And once they develop that negative reaction again and again and again, then they start to refuse all out to latch at all because it's negative, so they don't want to do it. So one thing that I always tell people who have babies that are really getting fussy at the breast is to not try for very long. So if that baby starts to fuss, you want to stop, move them away from the breast, put them up on your shoulder, cradle them, whatever may calm them down, and then potentially try again, or that's it for that particular feeding session. So really important to not keep repeating this experience that is causing this baby emotional distress, because things aren't going to get better if if baby keeps experiencing that. One thing I want to point out here in particular as a cause is torticollis. So this is something that is just important to be aware of, that especially if you have a report that a baby refuses to latch on one side and not the other, or seems to be fussier on one side than the other, or mom has pain on one side and not the other. So that indicates to you that there's something going on that's different on one side or the other. And it may all have to do with mom on that side, production or shape of nipple or whatever it may be. But it also, you should definitely look at the baby and look to see if there are signs of torticollis, which may also be associated with positional plagiocephaly. And if you see those signs, it may be that when the baby is on one side, they're perfectly comfortable, but as soon as they have to turn their head to the other side, it hurts. And they're gonna fuss if it hurts when they're eating. So something to look at, and then that can be tweaked with, first of all, treating the torticollis, but also giving the thinking about creative other positions to latch this baby so that they will not have to turn their head in the way that hurts. So if you have a baby who is not at the breast, then, or is refusing to latch at the breast, then first of all, we obviously need to feed this baby. So there's no lactation folks out there who are going to persist without feeding a baby. That's the most important thing. So this may require, depending on how far along this baby is, just spoon feeding, cup feeding the baby with either expressed milk or formula, or using a bottle. This is my little baby over here. One thing that can help with getting this baby back to a pleasurable experience at the breast and associating pleasure with being at the breast is skin to skin. Skin to skin can help in so many different ways. One is just the baby associating being full and cozy and comfy with being near the breast. Another is release of the oxytocin. So this may help with mom's stress level and mom's let down and flow of the milk. It also helps with the baby's self-regulation and growth and all of these things that can contribute to a more successful breastfeeding experience. So skin to skin is great. And skin to skin can be not just on mom, but in terms of specifically getting the baby back to breast, skin to skin with the mom is going to be helpful. So when mom is has the energy to do it after pumping, skin to skin is a great thing to do after your baby's fed. Paced bottle feeding is another thing to be aware of and to recommend in babies who are not doing well at the breast and mainly getting bottles or partially getting bottles, but you intend to try to get them back to the breast. So the point of paced bottle feeding is to make sure we're not overfeeding a baby. When we put a baby, kind of cradle them and put the bottle almost vertical, which is kind of the typical position that we put babies in for nursing or for bottle feeding, is that babies, that milk is going to flow out of that nipple no matter how slow of a flow or small nipple you have. So babies learn that they don't have to do much to get the milk that way. Gravity will do the job for them. And if they get the milk so easily that way, then especially if you've already got kind of a maybe sleepy baby, a baby that's not putting in too much effort or thinks that the breast is a negative experience, they're going to opt to take that bottle whenever they can. But paced bottle feeding, which is, again, I don't think we have time for the video here, but you can see in this picture how baby's a little bit more upright, almost sitting up, and you've got your bottle positioned horizontally so that only about half of the nipple should be filled with milk. Don't worry about baby taking in air. They're actually probably more likely to take in air if the milk is coming too quickly in a vertical position. And you also, not only do you need to position this way, but you need to watch baby's cues so that you're kind of mimicking what would happen at the breast. So if you think back to that lovely video that we watched, baby had to suck to get the milk. And then when they paused, no milk was coming, no swallowing was happening. And when they were ready to start eating again, they started eating again. That's when they get the milk. So we want to mimic that with paced bottle feeding. And When you start the bottle, you don't just stuff it in the mouth, but you let baby come to that bottle. So tickle the nose, tickle the nipple, wait for baby to open the mouth and ask for that bottle, then put the nipple in the baby's mouth, and then let baby eat. And whenever they take a break, then you kind of drop the bottle down just a little. You don't have to take the nipple all the way out of the mouth, but you drop the bottle so there's no more milk in the nipple, and baby can take that break for as long as they need to. And then when they're ready to start sucking again, they start sucking again. And that's when you put the bottle back up. So that also just, it makes the baby work a little harder at the bottle, so they're willing to work more at the breast. And it also helps to build that muscle memory. Oh, I need to suck to get the milk, so that they learn that that's what they need to do at the breast as well. Sometimes babies will latch at the breast, but then they will just sit there and not do anything because they're not used to having to really do that much at the bottle. So this is really important to show your patients and encourage them to do this. And it's not always easy to get people to do it because it does take longer and requires more attention on the parent part, but it really is helpful at preventing that bottle preference from happening. Okay, so there is a ton to say about the mastitis spectrum, which is our third big problem. And we don't have too much time, so we're going to kind of speed through it, but I'm going to be doing another lecture that is focused on this in a month. So there is a new protocol that has come out from the Academy of Breastfeeding Medicine, actually not so new anymore. It came out in 2022. And here it is. And it changes the way we think about what mastitis is and therefore how we treat it. And I threw engorgement in there as well, because you very well may see engorgement in your office in those first few days after a baby's born, when milk comes in, when we reach lactogenesis 2, and there is the onset of copious milk production. Oftentimes women will go through a period of time where they are engorged, and some of the things that we're going to talk about here can help in that time as well. So let's start by just talking about mastitis. What is it? I think when we talk about mastitis, we often think about infection, and it's not always infection. So mastitis itself is simply inflammation in the breast. Itis is always inflammation, so mast is breast, mastitis is inflammation. It can be that the main etiologies are either just purely inflammation for some reason. It can be bacterial, and inflammatory can lead to bacterial or infectious of some sort. And then autoimmune. So there are various reasons why people have heightened inflammation in their body, often related to autoimmune illness, either other, more underlying autoimmune problems, or sometimes there are ones specific to the breast. So it doesn't automatically, the symptoms may be similar no matter what the etiology is. So it's important to really look at what is going on, a big picture, to figure out what the treatment might be. It's not always going to be antibiotics. So lactational mastitis in particular is most commonly associated with a state of hyperlactation. So what happens is, with hyperlactation, or quote unquote oversupply, we end up being in this stage of just chronic fullness. The alveoli are just full of milk constantly, because there's so much milk that just keeps refilling even when you empty it. And when that happens, we now think that lactose actually is the element in milk that, in a full alveolus, will seep out of the alveolus and into the interstitial tissue in the breast, and lactose itself is inflammatory. So not allowing those breasts to be chronically full, or those alveoli to be chronically full, can decrease inflammation and help to prevent lactational mastitis. Same thing is going on with that period of engorgement during lactogenesis 2, that we've got this kind of milk is coming in and we don't necessarily have hyperlactation, but during that period, we're also having just soft tissue swelling. There's just tons of blood flow to the breast during that time, and it leads to edema and inflammation. That fullness is not necessarily all milk. And in hyperlactation, though the alveoli are full of milk, we still are having swelling and enlargement and tenderness more because of the edema and the inflammation, not necessarily because of the milk itself. Mammary dysbiosis, we also talked about. So certainly when the normal flora is thrown off in the breast, that can also lead to inflammation. So that is another cause. So when we look just real quickly at the spectrum, so just simplifying things, let's assume we've got hyperlactation plus or minus some element of dysbiosis. What happens, and we're going to show you over here too, what happens is here we've got a normal duct and normal mammary epithelium of the areola and the nipple. And when there is inflammation or mastitis of some type, we get this, swelling of the tissue around the duct. And as that's happening, that impinges on the duct and causes a narrowing of the duct. And if it's narrowed enough, it's going to cause an obstruction down on the bottom. And when there is an obstruction, then you may form like a little clump of milk because it can't get through. But the underlying problem is this inflammation, not that you have formed simply a little clot or clog of milk that needs to be pushed out in some way. That's what the previous thinking has been about what's going on in mastitis and plugged ducts. And really, we're going to go over this a little bit more, but really we need to think of it as a process of inflammation and more inflammation and more inflammation. And it's the inflammation that we need to treat, not trying to push this thing out, because we're never going to get it through this obstruction unless we decrease the swelling, which will open this duct back up again. So we need to start thinking about it in this sense. And then, just going back here, so we've got the ductal narrowing and the inflammatory mastitis, which then can become bacterial mastitis, which then can become phlegmon, which is kind of a pre-abscess, area that is just very, very intense inflammation that just dissolves over time and becomes this thick, goopy collection of milk and pus, which is an abscess. Same thing with a galactocele. So a galactocele can happen from ductal narrowing, which is not so much infectious in and of itself, but it is a cyst, a true cyst, true discrete fluid collection of milk that is just filling with milk. And if it's sitting there long enough and there's predisposition with dysbiosis, it can become infected as well. So abscesses and galactoceles ultimately usually need drainage to treat. Now, I'm going to try to wrap this up in 5 minutes. So treatment of the first stages. So we've got the engorgement, we maybe have some plugged ducts, maybe have some signs of early mastitis with some erythema and swelling of the breast. The first thing you want to do is, if there is hyperlactation, which there often is, you want to manage that. So we want to stop over pumping. Sometimes women get into a vicious cycle where they get a plugged duct. They feel like that is because their breasts were left full for too long, which to some extent it is because of that. And they start pumping more. They either pump on top of nursing, or they add on pump sessions in the middle of the night when their baby is now sleeping in order to try to keep their breast from being full for too long. But in reality, that's just telling your body to continue to make more and more and more milk, and it leads you into even more of a hyperlactation state. And so what we want to do is try to actually bring that milk production down slowly, and that this sometimes is very, very anxiety provoking for moms to do this, because they're really scared that they're going to get sick again. They're going to get another mastitis or plug duct if they don't keep pumping. So it really does take a lot of hand holding and education and reassurance and believing it on your side that this is going to work too. The first time I recommended it, I was a little nervous about it, but it actually works. So what you do is you stop pumping, or you start to decrease the pumping over time. And when this mom does start to feel full, and it's not time for their baby to eat, or not time typically for their next pump session, they can just express a small amount of milk, just enough to relieve that pressure and lead them to be more comfortable. They can either hand express or use a hand pump, or if they do use a haka or something like that, just for a very short amount of time, not keeping that haka sitting there, but just allowing that haka to draw off maybe a half an ounce or an ounce of milk. That decreases that inflammation. Lymphatic massage, which I'm going to show you a quick video of, not aggressive, harsh massage, which really, that's what we've recommended in the past to push that plug out, but really that just ends up leading to more inflammation and trauma if you think about it. And I don't know if she's still on here. She is. Dr. Moore is on this call as well, and she likes to say that that you're not pushing out you're not pushing out a plug, and thinking about the breast, which is a gland like other glands in our body. So think about your thyroid gland. You would never take your thyroid gland and mash and mash and mash on it if it were uncomfortable or something. You would never treat it that way. So think about the breast similarly. We do not want to cause trauma to the breast. Other things that we do for inflammation: ibuprofen, ice. I'm not going to go into details here, but block feeding can sometimes be helpful for managing hyperlactation. And then there are some medications that actually will help to actively decrease production. And for people who really have idiopathic hyperlactation, not caused by too much pumping, but it's just inherent for them, sometimes these medications are needed more in the long term, and actually birth control pills, estrogen, can be very helpful in this sense, in this situation. So again, just a little bit more about the same thing. So we want to treat that breast or that plug duct or mastitis like a sprained ankle. So you use ice, you use NSAIDs, you use rest, so that's the no aggressive massage, and elevate. Don't really elevate the breast, but lymphatic drainage helps that inflammation to drain. And then you can do this for 24 to 48 hours if you've got an early mastitis. And if it is not getting better, then start to consider needing more aggressive treatment with something like antibiotics if there's signs of infection being fever, body aches, muscle aches, chills, night sweats. These are things that we frequently see with infectious mastitis. And you can see mildly, some of those things very mild with inflammatory mastitis, but full on, like somebody thinks they've been hit by a truck and have the flu symptoms, that's probably infectious mastitis, because it actually leads to a state of bacteremia, which gives you those symptoms. Lecithin, that's just another one that makes the milk a little bit less sticky and clumpy, so it can help in these situations to just help some of that milk still get through those narrow ducts. So lecithin is a good idea in people who have a plug duct or mastitis or persistent engorgement. Again, just what not to do. So we don't want to do this aggressive massage. We don't really want to use heat. We might use heat in certain situations, like if there's also vasospasm, heat right on the nipples, or in people with low production who are, for whatever reason, having in this situation, sometimes heat right before expressing can help increase flow a bit. But generally ice, and then again, avoid these massagers and vibration. All of these things are just causing more trauma to the ducts and the tissue and leading to more inflammation and more recurrences of plugged ducts and mastitis. I do want to show this real quick if I've got a minute here. Really helpful video. All right. So very simple to do in the office in order to start the process of decreasing the inflammation, and also to teach your patient how to do it themselves. So this is what can be done over and over and over again, as much as necessary in women who are undergoing any sort of breast inflammation. And this was put out by IABLE, which is the Institute for the Advancement of Breastfeeding and Lactation Education, which is a wonderful resource for physician-oriented breastfeeding training. And Dr. Katrina Mitchell is the person doing the lymphatic massage in this video. And she has a wonderful website called the Physician Guide to Breastfeeding, which has amazing amounts of information geared towards physicians, but some of it's helpful for patients as well, on how to treat all sorts of problems. Abscess drainage, I just want to say really quickly, because we don't have time, there is detailed explanation of how to handle this at this website. And the main thing is that in the past, people, or the current way of treating abscesses tends to be, what's recommended is office needle aspiration, but the fluid in there is really thick and gucky, and usually that is not going to really get rid of, it's not going to do the job. And so an actual IND is really important, but it can be done with a small stab incision in the office. And then a drain or wick placement, not to suction, to allow the milk that is going to keep, milk as well as pus, that is going to keep filling, to drain, and therefore not cause a milk fistula. And it actually can heal up within just a few days if done this way. So important to know that this is how to do it, and to find somebody in your area, if it's not you, who can actually do this for you or do this for your patients. Okay, so I just want to go through some physician resources here that will be very helpful for you guys to know about. So Infant Risk is a great organization. If you have heard of Thomas Hale, who wrote the book Medications and Mother's Milk, or Mother's Milk and Medications, he has this organization called Infant Risk, which is fantastic. And there is an app that I think is $10 period, maybe $10 a year. And one that I'm not sure if it's still free for parents, but was free for non-medical people, that is fantastic, because it really shows you, both for pregnancy as well as for lactation, by months and trimesters what the safety level is. So, green is go, so green is safe. Kind of goes over all sorts of different facts. And then more specifically, if you click on the 0 to 6, it will tell you what we specifically know about it. And, unfortunately, with breastfeeding, with medications and breastfeeding, it's very, very hard to do research on that. It's hard to get anything IRB approved on pregnant women and babies and lactation. And so a lot of the information that we have is more extrapolated through, what is the molecular weight? Is it bioavailable? Is it, how much we can measure how much makes it into the breast milk. And therefore, if that much makes it into the breast milk and that much is bioavailable, the ultimate dose for the baby would be so tiny that it shouldn't affect them. So some of it is extrapolated, but we have information that could be very helpful there. And then this is another website called Trash the Pump and Dump that has information about when you should not give breast milk to babies based on not only medications, but also baby illnesses and maternal illnesses. And really, it's very, very rare that you actually need to pump and dump. So that's the most pressing thing that I want people to get from this, and that there are resources out there. LactMed has a lot of similar information as infant risk. And this is available through the National Library of Medicine. iAble, as I mentioned earlier, is a wonderful, wonderful resource for physician-oriented lactation education. So, and there's lots of resources on their website as well. And they have amazing conferences as well as just lectures, free-form lectures that you can sign up for fairly low cost. If you are a mother and lactating, or have patients who fit that description, there is a Facebook group and website called Dr. Milk. And again, lots of resources for physicians who are lactating. I mentioned this from Katrina Mitchell, her wonderful website, Physician Guide to Breastfeeding. All of the protocols that I mentioned are in the Journal of Breastfeeding Medicine. PSI, this is an amazing resource for mental health support for people who are lactating. There's an emergency line, as well as simply lots of help getting people local resources and groups and all sorts of support that's very important. And then local and national support groups for parents. So hopefully this has been helpful. Again, I will be doing another lecture in a month or so that is on specifically about the mastitis spectrum. So you can join for that to hear more about that. And you can contact me anytime through Doctors on social media if you have questions or need to reach out for any reason. So thank you for joining.